Good morning, everyone. Today we will talk about the pancreatitis. This disease will affect the pancreatic tissue. And we will talk about anatomy and histology of the pancreas, physiology of the pancreas, introduction to the pancreatitis, etiology and pathogenesis, then macroscopical and microscopical feature of disease, clinical feature and diagnosis, and finally disease. So first of all, we will go through short notes about the anatomy of the pancreas. The pancreas is an elongated organ situated beneath the bottom of the stomach, and it is extended from the C part of the duodenum, as shown here. This is the C part of the duodenum, to the hilum of the spleen. So this is the end to the hilum of the spleen, and the pancreas composed from the head of the pancreas, this part, body of the pancreas, and finally the tail of the pancreas. In the middle, we can see here, this ductal structure is the pancreatic duct, which is open to the duodenum. And this is the duodenum. This duct is also attached to the common bile duct here. And here in this slides, we can see the normal histology of the pancreas. And we can start from the first slide, which showed the whole histological appearance of the pancreas, which composed from the two main parts. The maximum part of the pancreas composed from the glandular structure, as shown here. This glandular structure called the exocrine part of the pancreas, which is responsible for the production and secretion of the digestive enzyme. And another part here, which is a faint blue color, called islet of Langerhans. This is the endocrine part of the pancreas, which is responsible of release and secretion of the several hormones to the circulation. The pancreas surrounded by the thin layer of the connective tissue, as shown here. From this connective tissue, there is several septa here from the connective tissue, which is need to separate the glandular structure and form from its several lobes or lobules, like this one, this one, this one, and this one. The second slide shows the magnification of the glandular structure, in which the acini composed from the cuboidal cell, as shown here, and arranged in the circular manner, or approximately circular manner. And another high power show the ductal structure of the pancreas, in which there is two types of the pancreatic ducts shown in this slide. The elongated one, which is lining by the cuboidal cell, represent the intercalated duct, which is carry the secretion from the acinar cell. This is the intercalated duct, and this secretion will be passed to another type of the duct here, which is a bit more circular and lining by the cuboidal cell. This is called intralobular duct. From this duct, the secretion passed to another type of the ducts, which is interlobar duct, and finally to the main pancreatic duct. Both types of the duct not shown in this slide. Last slide here show the islet of the Langerhans, which is composed from the several type of the cell, this type of the cell, and this cell arranged in the different way, but mostly near the capillary, as see here, this capillary, and this another one, because these cells responsible for the secretion of the hormone into the circulation. Now, physiology of the pancreas, as we mentioned previously, the exocrine part of the pancreas responsible for the secretion of the several type of the digestive enzyme. Here, trypsinogen, lipase, amylase, phospholipase, each one responsible for the catabolism of the specific type of the substance, like in the trypsinogen, responsible for the protein degradation or catabolism, lipase for the lipid, amylase for the starch, and phospholipase for the phospholipid. Endocrine portion of the pancreas responsible for the secretion of the several hormone, from which insulin is the most important one. This type of the hormone responsible for regulation of the blood glucose. So when the blood glucose go high in the circulation, So the insulin secreted and need to decrease its level by enhanced uptake of this substance from the cell, and this type of the hormone secreted by the beta type of the islet of the Langerhans, which is represent the most part of these islets. 70% approximately of the cell of the islet of the Langerhans is beta type cell. Glucagon is another hormone which is very important, also regulate the blood glucose, but it responds to decrease in the level of the blood glucose. When the level of the glucose in the blood is low, glucagon secreted and lead to catabolism of the glycogen, converted to glucose, and by this way increase the level of the blood glucose again. This type of the hormone secreted by the alpha type of the islet of the Langerhans, which represent the 20% of each of total part of the islet of the Langerhans. Somatostatin is another type of the hormone. This is inhibitory type of hormone, lead to inhibit the secretion of the insulin and glucagon, and it is secreted by the delta type of the cell, and polypeptide secreted by the PP cell of the islet of the Langerhans, and this is play a role in regulation of the appetite. Now, what is pancreatitis? Pancreatitis is the inflammatory disorder of the pancreatic tissue, in which the inflammation may be mild and may be severe, and can be divided to the acute pancreatitis and chronic pancreatitis according to the type of the inflammation affecting the tissue. So, for both type of the disease, acute or chronic, there are two main causative factors, gallstone and alcoholism, which present 80% of the causes of this disease. Another causes of this disease attributed to the acute pancreatitis, there is non-gallstone obstruction of the pancreatic duct, which may be due to the neoplasm or maybe to the parasitic infection like infection by the Ascaris-Lambert medicine, especially thiazide, which is act as diuretic, and also anticonvulsant drug is another causative factor. Infection by mumps and Coxsackie virus is another cause. Metabolic disorder like hypercalcemia and hyperlipoproteinemia, ischemia due to the embolism or thrombosis, vasculitis, trauma, maybe external trauma or iatrogenic trauma due to the surgery or due to the laparoscope or endoscopic procedure. Germline mutation is another important factor, which is affects the gene that's coding for both baby pancreatic enzyme or their inhibitor. And idiopathic disease or idiopathic pancreatitis represent 10% of these cases. Chronic pancreatitis again mostly come from ductal obstruction, which is come from the gallstone, and another type of the obstruction due to the neoplasm or parasitic infection, and also alcohol abuse is another important cause. Hereditary pancreatitis is due to the mutation in the gene coding for the pancreatic enzyme or their inhibitor, and mutation in the cystic fibrosis gene is another causative factor. Autoimmune pancreatitis, which is caused by the release of the antibody against S-inertial, IgG antibody or self-antibody, is the causative factor for the autoimmune pancreatitis. And again, idiopathic pancreatitis or chronic pancreatitis represented 20% of the cases. So, for both type acute and chronic pancreatitis, the pathogenesis story is the same. Whatever the cause, as see here, finally these causes lead to the cell injury and release of the pancreatic enzyme. Release of the pancreatic enzyme lead to many type of destruction inside the pancreatic tissue according to the type of the enzyme. In case of the alcoholism, like that can produce first injury to the acinar cell directly, or can be attributed to the pathogenesis by increased secretion of the pancreatic digestive enzyme, or increase secretion of the pancreatic fluid. And as we mentioned previously, gallstone or neoplasm, all of these factors can produce obstruction to release of the pancreatic enzyme and make this enzyme inside the pancreatic tissue. And finally, this enzyme, when it's activated, it will lead to the destructive condition. So, lipase will lead to the fatty necrosis. Phospholipase activation lead to coagulation necrosis. Elastase activation lead to the vascular damage and hemorrhage. Chymotrypsin activation lead to the edema and vascular damage. And kallikrein-kinin activation system lead to release of many pro-inflammatory factors, which is finally lead to the edema. What we can see grossly from the acute pancreatitis here, first slide show mild case of the acute pancreatitis in which the necrotic tissue can be scattered in the pancreatic tissue, as see here. Here, this is the white patchy area, clear. In the moderate of the pancreatitis, the necrotic area will be more clear and appear white in color, chalky appearance. Here, and another one. And there is hemorrhagic area surrounded the necrotic tissue, as shown here and here. Edema also can be recognized by the eyes, and we can see or feel the increase in the size or weight of the pancreas grossly. But still the pancreas keep its glandular structure in this area here as we can see. The more severe cases of the acute pancreatitis here represented by the acute hemorrhagic necrotizing pancreatitis, in which the hemorrhagic area is so severe, appear dark black color and extend for maximum part of the pancreas. And this slide shows the cross appearance of the chronic pancreatitis, in which the whole architecture of the pancreas change, and we can see the normal architecture of the pancreas lost. It's replaced by the fibrous tissue everywhere, as we can see here, another area. And this slide shows one causes of the chronic pancreatitis, in which the stone is accumulated here in the pancreatic ducts. These two slides show the histological appearance of the acute pancreatitis, and we can see the first slide here show the large necrotic area, fatty necrosis on the right side, as it is clear in this area, as we can see. While in the left side we can see many of the inflammatory changes, in which there is dilatation of the ducts, pancreatic ducts everywhere, and also we can see congestion of the blood vessels here and also many areas. This is red color, and hemorrhage also present here, as shown. In the middle area we can see the fibrous tissue, which is released from the fibroblast. In addition to that, we can see several dots, which is appear like dark blue dot, represent the infiltration of the inflammatory cell, which is polymorph nuclear cell, very clear in the second slide. As we can see here, the neutrophil infiltrate the tissue, and this infiltration is surrounded the fatty necrosis. As we can see here, this is why chalky material is the fatty necrosis of the pancreas. This slide shows the chronic inflammatory process of the pancreas and the chronic pancreatitis, and we can see here in the first slide the maximum part of the pancreas is lost. The glandular tissue is lost, replaced by the fibrous tissue everywhere, here and here and here. This is the fibrous tissue, and still the glandular tissue can keep it in the small area. This is the glandular tissue, and here. In more severe cases, the fibrous tissue will be more severe and take maximum part of the pancreas, as shown here. Okay. And another important thing is the dilatation of the pancreatic duct, which is filled by the proteinaceous material, which is very clear in this one. And this proteinaceous material will form the plug, which is lead to the obstruction of the pancreatic duct. And on the CT scan, this will be diagnostic feature. The calcification is very clear and can be visualized by the CT scan. Now, the clinical feature and diagnosis of the disease. In the acute pancreatitis, the patient most commonly come with the abdominal pain. The abdominal pain, this is maybe mild or maybe very severe and mimic the another condition of the acute abdomen. So we should be differentiated from the rupture cholecystitis and peptic ulcer perforation. Another condition that the patient can come in the severe cases, acute respiratory distress syndrome, shock, and renal failure. The diagnosis of acute pancreatitis can be done by the measuring of the serum amylase, which will be very high at the first 24 hours of the disease, followed by the increase in the serum lipase, hypocalcemia, and the enlarged inflamed organ can be visualized by the CT scan. In the chronic pancreatitis, the patient not come mostly with the abdominal pain, and the abdominal pain can be referred to the back, but the patient can come with another finding, jaundice, indigestion, and weight loss due to the malabsorption, maybe come with the diabetes mellitus due to the loss of the islet of the Langerhans, and mild fever also can be found in the patient. For the diagnosis of the chronic pancreatitis, amylase is not working good because it will be elevated, but the elevation is not high. In the severe and advanced stages of the disease, amylase can be go down because there is destruction of the acinar cells, so there is no more release of these hormones. So the another diagnostic factor can be done by measuring serum alkaline phosphatase and serum bilirubin, and also visualization of calcification, as we mentioned previously by the CT scan, is another option to diagnosis and can help in the diagnosis of the disease. Now, for management of the disease, most of the cases come to the hospital can be managed by keep the blood pressure normal and also keep the pancreas at rest. So contraindication should be done for the food or fluid intake, but other cases can be managed in different way when the patient come with the infection. So treatment with the antibiotic, especially for the gram-negative bacteria, should be chosen. And also this infection can be like increase to make the pancreatic abscess, and in the pancreatic abscess drainage or this abscess should be done. And another thing, some patients need to admit to the intensive care unit, in which maybe intra-arterial administration of the therapy for degradation of the pancreatic enzyme is an option. And when the patient come with the renal failure, so maybe need dialysis. So the management depend on the severity of the cases and the condition that patient have it when come to the hospital. Complication of this disease may be complicated by the pancreatic abscess, as we mentioned previously, and also pancreatic pseudocyst, chronic malabsorption, and pancreatic cancer. Thank you for listening.